I'd like to thank you all for signing on to today's webinar, Personal Protective Equipment Preservation and N95 Respirator Decontamination and Reuse. My name is Caroline Stakoyak, and I'm one of the program managers at the National Volunteer Fire Council. I will be your host today, and I'd like to start off with just a few quick housekeeping items. We will have a Q&A session following the presentation, and you are welcome to submit those questions at any time by using the Q&A box found within your Zoom screen or the chat feature. We are recording this webinar, and it will be available to our NVFC members. If you are unfamiliar with the National Volunteer Fire Council, we are the leading nonprofit membership association representing the interests of the National Volunteer Fire, EMS, and Rescue Services. We serve as the voice of the volunteer in the national arena to provide invaluable benefits for our first responders. And just a little bit about our membership. If you are currently not an NVFC member, our memberships are $18 per year, and that membership includes a $10,000 AD&D insurance policy, free online training through our virtual classroom, access to the member community volunteer voices, educational discounts to online universities and fire service trainings, eligibility to special programs such as our Globe Gear giveaway and educational scholarships, and last but not least, these webinars, which are free to members and non-members to benefit the fire service. Please support us by joining so that we can continue to bring these to you. You can visit nvfc.org/join. And with that, I am happy to introduce our speakers for today's webinar. Our first speaker is Chief Keith Bryant, who was sworn in as the U.S. Fire Administrator in August of 2017. Prior to his presidential appointment, he was the chief of the Oklahoma City Fire Department. He joined the OCFD in 1982 after serving as a U.S. Army firefighter crash rescue specialist. Chief Bryant also served with the Edmond Fire Department in Edmond, Oklahoma. Our next speaker is John F. Kerner, who is the Chemical, Biological, Radiological, Nuclear, and Explosives Advisor for Strategic Plans in the Office of the HHS, Assistant Secretary for Preparedness and Response. John is currently detailed to the FEMA ASPR Healthcare Resilience Task Force as Deputy to Captain Ignacio for the PPE Preservation Work Group. Finally, I will introduce Captain Ignacio, who is a U.S. Public Health Service officer currently serving at the Department of Homeland Security Federal Emergency Management Agency. He has been serving as the Chemical, Biological, Radiological, Nuclear Science Advisor and Program Manager for the Interagency Modeling and Atmospheric Assessment Center since 2014 in December. All right, and with that, I will give it over to Chief Bryant.
Well, thank you, Caroline. It's good to see you today, and my thanks also to Chairman Hirsch, and appreciate the invitation. NVFC is, again, one of our most valued partners in what we do with the Fire Administration, and you know, I can't thank the NVFC for all their support. One of our best partners in what we do and our training and education programs, and always somebody that's willing to jump in and help out with any project that we have. So sorry that we can't be in person with the group, and but hope everybody's doing well. I really do. I want to say that first and foremost, that a lot of challenges over the last few months, and you know, on top of the global pandemic that we've all been dealing with, and now we've had civil unrest added to that, and we know that wildland season is just kind of kicking up a little bit, and we got the news the other day from NOAA that we're maybe in store for a little bit tough hurricane season this year too. So a lot of challenges out there, and the volunteer departments out there have been doing great. I know that that they've struggled as well because of the issues that they face in terms of funding and so forth. So I can't thank you all enough for the work that you're doing out there, and not only in your communities, but again, to support what's going on nationally. And I hope, as I speak to you today, that everybody is holding up very well and staying safe and healthy. Before we get to our guest, which Caroline did a great job of introducing them, and they're going to take the bulk of the program today, I kind of wanted to let you know kind of what the fire administration's involvement with what's going on right now, and then pass some information on from our perspective, and also that of FEMA. And as with everything that's going on right now, it is rapidly changing and evolving. So we want a part of our purpose is to keep everybody as up to date as possible with the best and latest and most accurate information that we can provide, which is one reason why we're conducting this webinar today, and then the information that our guests will provide you. So I want to, as I mentioned that we have a lot of information posted on the Fire Administration's website. So if you hadn't taken a look at that as of yet, please do. So we're keeping that up to date. We're sending out a weekly news brief, if you will, with the latest information as we have it, and also doing a daily briefing as well. So please visit our website if you haven't, and hopefully there's some information there that'll be of benefit to you. But the information that we'll be presenting to you today is the latest and current up to the June 1st, based on current research, best practices, and so forth, as we're trying to keep track of. Just want to say this about best practices in decontamination and some of the issues that have been going on with PPE. I want to say this first and foremost. I wouldn't sit here today and visit with you and pretend that there haven't been issues with PPE supply, availability, and distribution. There certainly have been, and I know that that's made your challenges even more difficult. Hopefully I really do hope that that's improving. If not, we need to hear that, and we can certainly communicate that to the FEMA administrator as well as the supply chain task force. But just some numbers here in terms of what FEMA's done to this point in terms of PPE. A little over 92 million N95 respirators we've tried to get out there. 146 million surgical masks, 12.7 face shields, about 1 billion pairs of gloves, 32 million in gowns, and 200 of these shipments from overseas. And that's been FEMA's posture on this, is that they made a decision, FEMA leadership, not to supplant or circumvent what we would think of as the normal distribution system in terms of a supplier or vendor and their customers. We just tried to make sure that these items were available for those distributors to get to their customers. And absolutely there have been problems with that, and we've tried to work through those as best we can. And one of those ways, as I mentioned, was these overseas shipments, whereas normally where the bulk of these materials were coming from to begin with, would have to come over by ship. And so FEMA has made large cargo aircraft available to try and expedite those shipments as best as possible. And when they get here, the plan was to get those to what we knew to be the hot spots from the data in terms of infection rates and so forth. So that's kind of been the way we've done that. So coordinated about 200 of those supply flights from overseas to the United States, facilitated about 1,500 or so deliveries, including a 14-day supply of PPE to all Medicaid and Medicare certified nursing homes in the United States, which is obviously high on the priority list. Next, please. So again, we've been working closely with our federal partners to, again, try and help with the distribution of PPE, based on the current and projected needs as we know them. A lot of that information has come from the fire service. There was a survey that was put out here recently with the IFC on burn rates. And I think we've used that information to help know where that, to try and prioritize that PPE getting to in terms of shipments. In addition to that, the Defense Logistics Agency has secured about 60 Patel decontamination systems. We'll be talking a little bit about that later. For the sanitation of those N95 respirators, and hopefully we get more and more of those out there. And finally, FEMA and Health and Human Services have obligated about $6.2 billion for COVID-19 response activities. That brings us up to where we are now. Now, and I want to make this clear before we move on. This being a global pandemic, there's a global demand for these resources. And right now, the supply is still not keeping up with that demand. And just to be very, very honest and direct, I think that will be the case for this foreseeable future. It's just not keeping up with the demand. Hopefully some things are changed and where those items are manufactured and so forth, and we continue to make improvements so no one is doing without those very critical resources. Next, please. So in terms of the U.S. Fire Administration, as I said, we have personnel assigned to multiple task force, the joint FEMA HHS task force on pre-hospital issues and so forth. We have representatives on those. We certainly have members of our staff in the National Response Coordination Center, making sure that whatever resource needs that come up are being addressed. And certainly the sharing of information, training, and products for use by fire. Again, a lot of that information we're trying to put on our website, but again, staying in close contact with the major organizations such as the NVFC on a very regular basis. And we're also gathering a lot of data through our INFR system. And I wanted to speak about that just very briefly, that we have a COVID study, if you will, on INFRs that you can, when you report on INFRs, it actually plots where the response is either confirmed COVID cases or suspected COVID cases, the amount of resources devoted to those and so forth. So we're gathering some good data, and we're plotting that, a lot of that information on a map that we're sharing with everybody on our website. So if you haven't looked at that, please do. I think you'd find it beneficial in terms of informing you what's going on across the country. Probably we wouldn't be surprised anybody that the hot spots that we all hear about, that's where most of these cases are popping up at. But it also shows trends. And so, again, we're happy to share that information with everybody. It's available, as I said, on our website. And so to this point, we've collected information on about 135,000 emergency incidents from about 3,200 departments that are reporting on this special study. So hopefully that's of help to you. Again, any questions that you may have, any difficulties that you may be having, you can certainly share those with us, and we'll do our best to facilitate some type of response or assistance to you in that way. So that's my part of the program this afternoon. And right now, again, I want to turn it over to Mr. John Kerner, who will take us through the best practices for PPE preservation and decontamination. Mr. Kerner, thank you for being with us today.
All right, thank you, Chief. And I do have to say it's an honor to be on this dais with you, especially in front of such an esteemed crowd. I just took a look at the attendees and noted a number of folks that I know and that I've worked with in the past, and I appreciate your support here, and importantly, those that don't know me, I appreciate you willing to hear me out. One of the things you may not know is that I come from a community that was entirely served for fire and EMS by a volunteer fire company. And there's no hospitals in town. The closest hospital is 35 miles away, and just a couple of physicians that essentially operate out of their house. And you know, I really appreciate, recognize, and acknowledge the expertise and the challenges that go along with being a member of a volunteer corps, and the dedication that's necessary. And point two is, you know, with that, I understand that in those communities where you have had COVID challenges or with respect to just PPE in general, where you haven't been able to get the materials you need to do your day job in terms of fire and rescue. I appreciate the challenges you've had for the last few months, and I honor the responses and the work that you've done in the past particularly troubling week on top of that. So, and in some communities where, as Chief Bryant mentioned, we're looking at the coming fires, forest fires. We're looking at the coming storms. We're always we have emergency in our name, and that requires us to maintain readiness for everything that's coming. So I'm going to talk a bit about PPE best practices, and whoops, I'm moving a little quick here. Hold on. And the purpose really is to provide a venue to reflect on some of these practices for the preservation of equipment and in healthcare and emergency response, and thinking about now and future emergency operations. Now, you might ask why FEMA and big HHS have implemented this PPE preservation construct beyond what the FDA has implemented with their emergency use authorizations and what the CDC has issued in guidance. And the main reason why is because at the beginning of the COVID operations, that supply chain task force was established under 4 pillars, and the first pillar being based on extant protective equipment and other supplies, respirator, ventilators, and such. Coming up with a rational strategy and construct for allocation of those supplies to get to the folks that have a really high demand curve now, and then have some consideration for those that are in need despite not having a lot of COVID in their location. And that's the allocation component. The acceleration component has to do with enhancing industrial manufacturing capability in the short term, and also establishing the air bridge and such that you've heard about to begin accelerating via air versus waiting 3 months for ships to come, the shipments of PPE. And then the last is the third component of that stool is the expansion, trying to get domestic production enhanced, and you've seen the Domestic Production Act discussions and such, so that we don't run into this issue moving forward, and we have a sustainable mechanism for the United States in the future. And then the fourth leg of that stool is the preservation of medical supplies, in our case, particular PPE preservation. And that's our tasker that Captain Ignacio brought over from the Supply Chain Task Force to the Healthcare Resilience Task Force, and to figure out either unique or novel best practices and communication strategies so that we can help our providers in the field and in the hospitals, not go through their equipment so fast, 2, come up with thoughts and mechanisms to really provide a safety net for dwindling supplies. And then 3, very importantly, and I think most importantly, is protect those providers, protect those responders in all cases, so that we never get to a true scarce resources position. So in developing our PPE preservation strategy, we did employ the emergency use authorizations from the FDA, the strategies from the CDC that you've seen, and the guidance from the Fire Academy and many others that you've seen. And then we actually took another step, and because of the urgency of the issue, going back to the beginning of March, really reaching out to those areas that were either in need or are in need and stressed because of COVID response, but importantly also recognizing that in places like Wyoming, where they had a low case count, they still had limited access to care or to personal protective equipment and try to get a better understanding through that entire spectrum of exactly what means and mechanisms folks are using to limit their PPE use and other strategies to enhance availability. The fact sheet that was published, I believe at the beginning of April now, it seems like years ago, has been put through focus groups for sort of a peer review, and then it's also been put through interagency review. It also links up to some conversations that, in fact, I just got off the meeting with our ad hoc technical working group to discuss the efficacy of decontamination and the viability of the respiratory protection in particular, but other pieces of PPE after various decontamination technologies have been employed. So when we're talking about personal protective equipment, I just want to make sure that we're all considering that we're not strictly talking about N95s, although in the decontamination section that Lido will get to in a moment, we are talking generally about N95s, but when we're talking about preservation of protective equipment, we're talking about the full ensemble that will be used for patient care, whether in the first responder environment or elsewhere, and the entire spectrum and ensemble that would be used. Now, this is a critical piece of understanding strategically that, you see the kind of rainbow across the top here, going from conventional strategies, that's what we do on a normal day, to contingency strategies, that's what we do in practice on a mass cal or another big event where we might respond to and understand that we've got to do some things that we wouldn't normally do in order to maintain protection of our employees and our patients, so that we never reach that crisis in the red where we have to take unusual positions and methods to protect our employees. And that's what the basis of this is, and it's got basis across fire, EMS, the medical community, national academies, fire, NFPA, and such. So we did publish a fact sheet on April 12th. It's currently under review. I was hoping that I might have the updates completed before this meeting, but we just got the update review back on Thursday, I believe, last week. So we're still working on that. But you can access that fact sheet at the link below, and you'll have access to this presentation to follow that link. And it provides an overall summary of some of the best practices that we've gleaned from the field, that we've assembled from our federal partners, many of whom sit on our working group, and come up with a construct that what we can do is three primary things, and that is reduce the demand signal for personal protective equipment, to identify strategies and materials that can be reused, and to repurpose materials that otherwise, and sources that otherwise wouldn't be part of our normal way of doing business. And I think importantly, the repurposed component is probably more accurately represented as the second piece, with reuse being a end stage contingency strategy, but repurposing also being defined as rather than, say, taking a drug, a seizure medicine that a paramedic would normally administer, for a seizure, finding another use for that drug. In this case, we're talking about finding other sources and types of material to apply instead of the standard practice material that we would use. And I'll get more to that in a moment. So the fact sheet amplifies the CDC strategies and kind of links them together with the overall FEMA construct, the four legs of the stool that I just described, suggests those appropriate actions that you may select from, or that you may already be implementing, and then other thoughts about additional things you can do. One of the important things is that all facilities now need to begin using some of the contingency strategies. Yes, this goes back to April, but I think that, as Chief Bryant recognized, that we're not going to buy our way out of this anytime in the short term. Manufacturers are saying that they'll be able to ramp things up in a few months, or they are ramping things up with higher levels of deliverables in the few months. But in the meantime, while we have pop-ups and outbreaks through the summer, particularly in the rural areas or the communities that have been less affected than the bigger cities during the current phase of the response, we need to consider that this is going to be ongoing. And another complicating factor is things like the fact that the economy is opening up, and that other industries are going to have a demand signal for the same materials, and that needs to be balanced for the protection of the providers and the responders, but also for the overall industry's ability to provide these materials at what was a kind of a just-in-time inventory practice. The pillars of practice here, again, reduce, reuse, repurpose, and there's various components under those. How do we do it? One of the things that you've probably heard, we've been encouraging across the board, non-healthcare industries and other healthcare components that have not been deemed necessary to function during the mitigation measures should really either start switching the type of PPE they use, or find other ways to conduct their operations without the necessity of personal protective equipment. For instance, in construction, it is very common to use N95s as dust protection and dispose of those and move away. So alternative sources like elastomeric half pieces that can be used for a much longer time may be more appropriate for them to use as well, and preserve that PPE for the medical folks and the first responders. Maintaining our social distancing, we're all familiar with that. And then simple things, and this actually came from the EMS community, that third bullet about conducting patient and civilian interactions, or interactions with civilians or the population outdoors or in larger spaces when you can. A couple of weeks ago, I had a discussion with the international fire chiefs, and I noted that the day before, on my way back from the grocery store, that I saw a fire engine and EMS evaluating a patient outside on the steps of their house with one EMT or paramedic, I don't know which, doing that initial assessment in appropriate personal protective equipment, while the firefighters, and in DC it's firefighter EMT, stood at distance so that they didn't have to suit up right away unless there was a determination that that patient needed to be moved. That alone, that exercise alone, I don't know what the outcome was, whether that patient had to be transported, but that exercise alone, assuming the patient was allowed to either remain in place or have a limited attendant transport, probably saved the personal protective equipment for the 8 others that were standing there. And then if that patient was transported, it would simply be whoever was driving the rig and whoever's attending the patient. There is a hierarchy of controls that I think we're all familiar with in our communities, respective communities, and that the first thing is we try not to expose ourselves to the hazard. We try to replace the hazard with something less hazardous, implement engineering controls, implement administrative controls, just people doing things differently. And then the last line of attack is supposed to be personal protective equipment. interestingly enough, for obvious reasons in the fire service, but when we're talking about EMS and healthcare and hospitals, the design over the last decade or so has really been to shift more towards PPE to facilitate close-in patient activities versus thinking about other ways that we may not need to expose ourselves when there's a clear and present hazard. So what is reducing? Reducing is reducing the usage rate of PPE, using things like engineering controls, barriers, and technologies. I'm not going to read through all of these, but you can avail yourself of these on the fact sheet. But importantly, there are kind of things that you wouldn't normally associate with personal protection or health and safety, such as the implementation of telemedical techniques in order to evaluate people outside of healthcare. You may have heard a couple of instances that folks in the prison population are being seen in court by video, so that they don't need to, one, leave that facility that they're in custody in, and two, they don't create a greater hazard to those in the courthouse. Things as simple as placing monitor towers and ventilator controls outside of patients' rooms, which many providers were not comfortable with initially, but has become almost standard practice, kind of limits the need to enter the room every time you're monitoring that patient, and particularly those patients that are ventilated. Of course, we want to have that interpersonal interaction with a patient. But the reality is that if you've got a vent in, if you're intubated, you don't have the ability to interact with that provider. Additional examples of reusage. This is one of the, this image shows us one of the alternate care sites that were implemented a couple of months ago. And you notice that these convention centers are kind of optimal because they do give that ability for a larger space, such as I mentioned before, but simple other guidance such as minimizing the number of people in contact with a patient or with the population, working in cohorts of patients and populations. If the whole family is calling and presenting with a cough, seeing them collectively versus individually is helpful. Consolidating those activities and such. One of the things that people are getting much better at, and Chief Bryant, I might reach out to you on some of the polling that you've been doing in terms of gathering information and data, and because we've had a focus in the last few weeks on getting a much better understanding of what that PPE demand signal looks like in the field, and importantly, what the scarcity assessment or reality is in the field, other than pieces and parts, and trying to consolidate a way to integrate that into a more strategic way to think about allocation and distribution. But part of that is for this population to understand your PPE requirements and burn rates. And when you get those local calls to report them up, to take that time that it takes to report up, because we can't have, and the state can't have, and the county can't have visibility on what the truth of the situation is unless we're hearing from the horse's mouth. And then there's some other things about extended use times and enforcement guidance from OSHA. Now, reuse, I won't spend too much time on this. I'll let Lito deal mostly with this. But to the extent that this latches up to the strategic approach to a PPE preservation, understanding that reuse is not limited to decontamination. It also applies and extends, and prior to decontamination, looks at extended PPE use policies, taking those N95s and using them for more than one patient at a time, finding ways to have the limited PPE issued and rotating them amongst that individual so that they're not necessarily wearing the same mask every day, but they have a supply that they can rotate out. And then once we get to, which in some places has been true, some of that crisis stage, Captain Ignacio will speak much more to the decontamination techniques. Now with reuse, I think it's important, and at the end when we have the feedback session, I think it's important for us to, one, help you understand that the utilization of elastomeric half mask respiratory protection can be very useful in limiting the amount of disposable products that are necessary. And then when implemented in the construct of a respiratory protection program with appropriate training and fitting and decontamination, disinfection procedures, can really be a game changer, particularly when we're in the smaller communities that may not reach that prioritization within the disposable allocation constructs, until we can kind of fix that discussion, which is a systematic discussion. So you imagine it's challenging. I'd be interested in people's perspectives on substituting out 10 or 15 N95s a day to one elastomeric filtering or one elastomeric half mask respirator that can last up to a year before even having to change the cartridges. And then repurposing kind of applies in a similar vein to utilizing other NIOSH-approved respiratory protection. You did see in the prior slide the PAPRs, and I know in particular when we're looking at this time of year as we're transitioning from spring to summer, and we've had a 90-degree day yesterday. I can't imagine even wearing an N95 in the field, not to mention such as something like an elastomeric respirator, when something like a PAPR, should they be available, which I've done this when I've done anthrax sampling, when air handling systems in facilities back during Amerithrax, the first guidance is you shut off your air handler if you believe you've had a white powder incident. And, so in DC, you get a 90, 100-degree building pretty quickly. I can't imagine having done those sampling operations without a PAPR, simply from the heat stress and the comfort and the time necessary to conduct the operation. Using beyond expiration dates, and then using some of the imported respiratory protections are all part of that. So obviously, this all comes in the context of the things we are most familiar with, and that is protecting our employees and providing them appropriate training and guidance in order to execute the alternatives or the new knowledge that we're giving them in order to protect themselves, protect their patient population. And I don't need to talk to this group about the importance of training and training to a standard, and sometimes having to rebuild that standard in order to meet today's march. All right, so I'm going to put this up to Captain Ignacio's talk, and I think we've got a couple of questions in the chat, and Rick and Mike, I'm noting those, and we'll get to those at the end of our discussion here, just to make sure that you hear the full discussion from Captain Ignacio. So Captain Ignacio, I'm going to, you've got control, or?
Yep. Whichever.
Yeah.
Yeah. Go. If I can have the slides be controlled, that'd be great. So I'm Captain Ignacio. I am an industrial hygienist, environmental health officer with the U.S. Public Health Service. Currently assigned to DHS as the FEMA CVR and Science Advisor. And I want to thank Chief Hirsch and Chief Bryant for the introduction and the opportunity to speak with you today with John. So next slide, please. So this whole idea of decontamination and reuse of disposable N95 respirators is really a best practice for reusing, which is one of the pillars of the PPE preservation. We want to do it safely and obviously reuse it so that it can extend the life of the N95 in this particular presentation. Next slide. So when we talk about N95 decontamination and reuse, we're really talking about FDA guidance and CDC guidance when it comes to crisis capacity. So we're not talking about a steady state situation where you would necessarily need to do N95 decontamination reuse. However, given the concern for a future resurgence of COVID-19 in the fall or winter timeframe, one of the things that we are messaging to the healthcare and EMS communities is the possibility of, even though you might have a good supply now of N95, you should consider decontaminating the used N95s and stockpiling those decontaminated respirators in the event that you reach another crisis capacity shortage when a resurgence occurs. Obviously not required, it's simply guidance or a consideration for folks to look at rather than to burn through your existing supplies of N95 respirators and then us, the society, US, experiencing the same challenges that we did with this current wave. Next slide. And so what CDC has done, as well as FDA, is they looked at the literature to try to understand what are the various methods that have been looked at by various academic, private institutions with regards to the effectiveness of decontamination of disposable respirators, and at the same time determining if those methods actually impacted adversely the fit performance or the filtration. What they have found is that the ones that seem to be the most promising based upon current research is the BHP method, which is the vaporous hydrogen peroxide, the moist heat, and the UV germicidal methods seem to be the ones that have shown both efficacy to kill microbes and also maintaining the integrity of the filtration performance of an N95 respirator as well as its fit. There are certain exceptions which they did find with regards in particular with UV. When folks subjected UV, obviously the more effective in killing, for example, viruses was proportional to the amount of energy that the respirators were subjected to, but unfortunately it also showed significant material degradation of the material durability at higher doses, which kind of makes sense, right? Because ultraviolet essentially burns the material that you're subjecting it to, and that's exactly what happens when you start increasing the joules per square centimeter. The moist heat they found over time, after 3 cycles, they started to see some respirators start to get compromised around the seal. And then when it came to vaporous hydrogen peroxide, after about 30 cycles, they started to see degradation in the straps. Next slide. So these are some of the specific reports. There was a Patel report using the Biocoil Claris hydrogen peroxide vapor generator, which is currently what is in the Patel critical care decontamination systems. Bergman also looked at the room biodecontamination, such as Biocoil, as well as the Claris hydrogen peroxide vapor. And then the Kenny study looked at Biocoil as well when it came to looking at testing against geobacillus and these bacteriophages. They found greater than 99%. And then in this slide, they show the UV, the ultraviolet germicidal effectiveness. Here, they actually tested it on MERS coronavirus and SARS coronavirus and H1N1, as well as influenza variants, and showed 99% effectiveness. The microwave generated steam, where you essentially, or microwave steam bags, they did also find efficaciousness primarily with H1N1 and MS2 bacteriophages. Here, you're essentially boiling water, and then the steam from that is what actually does the killing, the antimicrobial action. Next slide. And then moist heat incubation was looked at. What has not been really evaluated was the effectiveness of ethylene oxide and liquid hydrogen peroxide. Ethylene oxide, of course, is identified as a carcinogen, so there are some concerns there. But my understanding is there is a vendor that is looking at ETO as a potential decontaminant for respirators. Next slide. So, basically, you have these 5 hospital sterilizers. These are sterilizers that are currently in use in a lot of healthcare facilities that all use vaporous hydrogen peroxide. And they have been issued emergency use authorizations by the FDA for use in N95 decontamination. You do have to read the emergency use authorization because some of these models allow for up to the same respirator to be decontaminated as high as 10 times and some as high as only 2. And also there are certain capacity requirements like I believe the Sterilucent, you can only put 5 at a time versus the ASP Sterad, I believe it's 10 quantities. So it varies tremendously. So you do have to be specific. The Patel critical care decon system, which you've heard a lot about in the news, that has a volume. So this decon chamber that you see depicted in the slide is authorized by FDA to decontaminate up to 10,000 N95 respirators at one time. Next slide. And then with the critical care decon system, and the reason I kind of bring this up is this is the one that currently is funded under the Department of Health and Human Services for use by healthcare facilities, as well as EMS agencies for free of charge. So it's fully paid for by Health and Human Services based upon state resource requests to have that in their jurisdictions. And right now there are about 47 jurisdictions that have asked for these systems to be put in place and are currently operational. But essentially either an EMS agency or a healthcare facility would sign up online. They would be then assigned some sort of site code. And then there are labeling instructions for the respirator. That site code is what you would put on the respirator so the Patel staff know where it goes. And then either the EMS agency or the fire service or whomever, the hospital, would then have a procedure to collect their used N95 respirators, place them in a biohazard bag, and then they would be sending them to the Patel site for decontamination. And then after it's decontaminated, the healthcare facility or EMS agency would pick them up. And then there would be a tag on the respirator indicating the number of times that respirator was decontaminated using the Patel system. By the way, that same annotation of the number of times a respirator is decontaminated is the same process essentially with the hospital sterilizers, because all of them, regardless of whether it's a Sterilucent, ASP Sterad, or the Patel system, there is a limit to the number of times you can subject an N95 respirator to vaporous hydrogen peroxide. Next slide. So when it comes to decontamination reuse of N95, right, it is a implementation measure for reuse under our PPE preservation strategy. We still recommend, as John described, this hierarchy of controls where we really try to use PPE only as a last measure after elimination, substitution, engineering controls, and safe work practices are implemented. Under COVID-19 crisis, I just want to make this very clear, with the FDA EUA for use in a healthcare setting, those systems that I described, N95 respirators are safe for decontamination and reuse. I know there have been some concerns about how safe it is. CDC and FDA have all said in their messaging that they deem that this is an appropriate option when facilities or EMS agencies, first responders, are faced with critical shortages of N95 respirators. All right. And I am, with John and with Chief Bryant, open to questions. Thank you so much.
Okay, great. Thank you all for your presentations. We do have a few questions that we can begin with. And please, to our audience, continue submitting questions as you have them. If we're unable to get to those today, we can reach out to you personally. All right. Our first question, respirators such as N95 require fit testing. How does decontamination impact the quality of the fit test, and is there any guidance?
So currently, in the research that I cited from that the CDC and the FDA collected, found that the fit tests overall, particularly for those top three, the vaporous hydrogen peroxide, moist heat, and the UV, found if it was done within that cycle, maximum cycle times, the fit test, the fit of the respirator remained the same. So it wasn't going to shrink, I guess is what I'm basically saying. So it's not going to shrink the size of the respirator. So if you were to reuse the same respirator that you decontaminated prior to, it should the fit is the same.
Yeah,
Great.
and on top of that, there is the ad hoc technical working group that's examining standardization, and many of the folks that are on that standards group, you're all familiar with from NFPA and from ASTM. And ASTM is currently working to kind of catalog standardized methods to evaluate not just the efficacy of the kill, but also kind of acknowledging NIOSH's fit test criteria, a fit factor of 100, and material degradation.
All right, thank you both. Our next question, what are your recommendations for firefighters to wear on medical calls? Structural firefighting gear, gowns, long sleeve shirts, do you have recommendations on that?
For a medical call, you know, it's standard practice. The real important thing is to think about some of the alternative strategies, as I kind of described, in that you know, trying to have if you have to enter the home in order to do that initial assessment, that initial evaluation of the patient, have one, if it's safe to do so, have one do that initial entry, wearing what you would normally wear for an infectious disease call. Think tuberculosis, think you know, any of the other sorts of complaints that come. And if you are in a contingency or crisis position, if you're wearing an elastomeric instead of an N95, that's a great way to go. You know, just understanding that as part of this reduce, reuse, repurpose, some of these are administrative controls rather than personal protective equipment controls. And you will see some guidance out on the CDC/NIOSH site as to how to address this. But in additionally, Dr. Kramer from NHTSA has been putting things out on the NHTSA site to help guide those discussions.
Thank you. Our next question is for Mr. Kerner, I believe. In regards to the half mask face piece respirators, Mr. Kerner said they could go for a year. Has there been any evidence to show that? Could this be considered a long-term solution for providers in the future?
Yeah, so our PPE preservation working group is looking very hard, along with the supply chain task force and other experts at NIOSH and at FDA, to examine the applicability of the elastomerics to this entire workforce, and that's what I mean by the entire healthcare workforce. And it does seem that based on discussions with the manufacturers and the understandings from NIOSH, who really is the arbiter here, and some other thoughts as we're thinking about stockpiling, the analysis, the global analysis that's coming together is that yes, first of all, these are reusable, they're intended to be reused, and two, when the question came to the filters and the filter changes, as long as there is a the plastic covering over the filter, because there's a couple of different kinds of HEPA filters that go with the elastomerics. As long as you can clean the outside of that, as long as the filter itself isn't soiled, then the remainder of the material can be effectively cleaned and decontaminated. And yes, if you had a blood spatter on the filter itself, obviously you discard that filter just like you would any other piece of equipment that's intended to be disposable. But the face piece itself is designed to be disinfected and decontaminated, and that becomes part of your respiratory protection program.
And if I can answer this, because I'm seeing some questions related to the N95 along the similar vein. All of the EOAs, the emergency use authorizations for the sterilants, the hospital sterilizers, and the Patel system all indicate that if your N95 respirator is soiled with bodily fluids, dirt, cosmetic makeup, gasoline, and so forth, it pretty much renders that N95 useless when it comes to decontamination, because the vaporous hydrogen peroxide will not penetrate those soil or dirtied area. Also, it also says that if it's physically damaged, so one of the questions is, what if you start to feel softness in the material? Then yeah, then the N95 is not suitable for wear. So you do need to follow the manufacturer's instructions as well as the EUA instructions, or when it comes to what to look for after a decontamination cycle is done on the N95. But even that, before you even put it in a decon chamber, whether it's the hospital sterilizers or the Patel system, you need to make sure it's not soiled or physically damaged to begin with.
Thank you. I think we'll have time for just one more question, and I think this is sort of a two-piece question, and you may have answered this in the presentation, but I'll go ahead and ask it just in case. The first part is UVC light disinfecting practices supported by and/or recommended by the group. And then the second part of that question is, if so, if a fire district creates a UVC disinfecting cabinet, would this be an acceptable means to properly decon respirators?
Yeah, I've heard that there are some organizations, I'll let John chime in. It's really hard for us, for either John or I, to say whether or not it's efficacious or not without actually doing a study on that. You can certainly, and this is again, I'm very focused on the audience. This is outside the healthcare facility. I mean, you could conceivably read some of the citations from the UVC article that was cited by CDC as showing the efficacy of UV, to see if you might be able to put something together, but without any very specific, definitive studies on the energy levels that you're using on the UVC, the length of time, the duration, and then actually verifying the material degradation or not of the N95. It's really hard for either of us to say whether or not that's a recommended method. Yeah.
Yeah, I agree. I agree, Lito. The first folks that really looked at this hard and have established evidence in terms of efficacy and the absence of degradation of the material are University of Nebraska at their biocontainment facility. I would encourage everybody to take a look at the procedures. You can find them on the web that they've promulgated. I know that many organizations are, in fact, utilizing that technology and trying to establish parameters that are similar, particularly those of you that may have implemented UV systems within your ambulances. But you do understand that shadowing, energy, there's a lot of, one of the things that makes modern ambulances kind of conducive to using UV for disinfection or decontamination is because there's a lot of reflective surfaces. So all those things need to be considered. And Lito's right, we can't recommend, but there are folks that are out there doing it and are relying that as a PPE preservation strategy.
All right. Well, thank you all so much. Thank you for our attendees for joining us. I believe we are at the end of our time together today. Thank you again to Captain Ignacio, Mr. Kearney, and Chief Bryant for joining us today. If you have questions or you have questions that weren't answered, please email me. My contact information is on the screen, caroline@nvfc.org, and we will try to get those questions answered to you. If you are an NVFC member and you'd like to start a conversation, I will begin a discussion on our Volunteer Voices forum. Please feel free to jump in. And lastly, we do have a survey. We would appreciate it if you could take our survey to let us know how we're doing on our webinar series. And with that, I hope everyone has a great afternoon.
Thank you so much.
Yeah,
Thanks so much.
Good luck on any coming fights.
Yeah. Pleasure.
Bye, everyone.
Pleasure to be with you today, Caroline, and everybody joining in. Thank you so much for the opportunity.